Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. This is the second episode of a three-part series about the 2021 ACR Vasculitis Foundation guidelines for the management of systemic vasculitis. In the first episode, we discussed the recommendations for the management of ANCA-associated vasculitis. On today's episode, we'll focus our discussions on Giant Cell Arteritis and Takayasu arteritis. Dr. Sharon Chung, the lead investigator of the project, will again guide us through the recommendations, highlighting new or surprising conclusions, gaps in our knowledge, as well as instances in which the recommendations may not be applicable. We discuss controversial topics such as the role of temporal artery ultrasound and temporal artery biopsies for the diagnosis of GCA. We discuss the utility of tocilizumab for the treatment of GCA, the need for non-invasive large vessel imaging, TNF inhibitors to treat Takayasu, and the role of surgery. We'll also take a step back and discuss the composition of the panel that drafted these recommendations and how the project came together. We'll also talk about the involvement of patients in the development of these guidelines. So who is Dr. Sharon Chung? Well, in addition to being the lead investigator of this project, she also directs the Vasculitis Clinic at UCSF and conducts research on genetic and epigenetic factors that influence the development of autoimmunity. And now, on to our show. Sharon, thank you for coming again to help us discuss the new vasculitis guidelines.
Great to be here.
So today we'll be talking about large vessel vasculitis. Before we get started, I wanted to ask you about a little bit more about the development of the guidelines and who came up with these guidelines. Who was part of this committee?
You know, I mentioned this committee, but this committee actually had multiple parts. There was the core team, which was myself and 6 other individuals who initially came up with the scope of the project. We were then helped out by an expert panel, which helped define the scope of the project, as well as the questions that would be asked for this guideline effort. We then also had a literature review team, which I would say probably undertook one of the largest literature reviews ever conducted for a guideline project for the American College of Rheumatology. They started out with, I think, around over 11,000 papers to consider for this effort.
Unbelievable.
And then at the end of it all, we had a voting panel, and it's that voting panel which formally crafted the recommendations. It's that voting panel had to reach a 70% consensus in order for a recommendation to move forward. So I use this committee, the committee as a broad term, but we really had just multiple groups of people behind this effort.
And what was the role of patients throughout the development of these guidelines?
So once we had what we call our evidence report, the evidence for each of the PICO questions, we convened a patient panel. And the patient panel had patients with different types of vasculitis, GCA, Takayasu's, ANCA-associated vasculitis, PA, and et cetera. And we brought to them specific questions. For example, questions regarding glucocorticoid use, questions regarding preference for one therapy over another therapy to get their input. And once we had their input, we convened our formal voting panel meeting where we voted on those recommendations with incorporating the input from the patient panel.
Fantastic. So let's dive in. I'm sure we've all been presented with patients that we think may have giant cell arteritis. And there's always a struggle about how to diagnose them. I know one of the most important things that I think about is in somebody with with, new onset headaches or, intermittent vision loss is getting inflammatory markers. And that's sort of the first step. But then where do we go? What does the ACR recommend is sort of the best next step in diagnosing patients with GCA?
I think my answer to this question really reflects differences in practices around the world. So there's always been interest in using non-invasive modalities to help diagnose GCA, primarily ultrasound in Europe. And in Europe, and in the EULAR guidelines, ultrasound and imaging modalities are ranked in some ways very highly to help diagnose disease. It's essentially their first step. Unfortunately, in the United States, we don't have the expertise with temporal artery ultrasound that our colleagues in Europe have. They receive special training on, how to do the temporal artery ultrasound and how to interpret the results. And unfortunately, in the vast majority of clinical practices in the US, our ultrasound technicians and our rheumatologists don't have that expertise. So we don't have the performance characteristics of temporal artery ultrasound in this country that our colleagues in Europe do. Because of that, the guidelines at this point still recommend temporal artery biopsy as the diagnostic tool over an imaging study such as ultrasound. And I hope this lights a fire under people and causes them to gain more experience with ultrasound or have their ultrasound technicians gain this experience such that we can offer this therapy more widely in the United States.
Fantastic. So still for diagnosis, at least in the US, is a temporal artery biopsy. Should we go for one? Should we go for both?
So right now, I would say the guidelines recommend one. Most of the time, you will be able to get the answer that you need with one. If for some reason you have a strong suspicion and the biopsy is negative, you can go for the other.
And once the diagnosis of GCA is made, is there a role for further imaging?
So one of the more recent realizations in, GCA is recognizing the high incidence and prevalence of large vessel involvement in GCA. So thoracic aortic involvement, abdominal aortic involvement, subclavian artery involvement. So in the guidelines, we would recommend that a person who has been diagnosed with GCA should undergo large vessel imaging to identify large vessel involvement.
That's fantastic. So something like a CTA or a MRA of the chest is what you would recommend?
There are definite, probably regional and expertise preferences. I tend to use more MRA in my practice because there's less radiation involved, but CTA is also definitely a reasonable option. I would say that there are also other investigators who are using PET, FDG PET and PET CT. We don't have as easy access to that at our institution, but there are great studies coming out of the NIH showing how PET may be reflective of disease activity. So that's, I think, a new and developing area.
Fantastic. Okay, so my patient actually got a biopsy and it was positive, so it made the diagnosis fairly easy. We didn't have to think about, a contralateral biopsy. So certainly I know that glucocorticoids are part of treatment. Should I be using anything else?
So glucocorticoids are the mainstay of treatment, but I think we all recognize the toxicity of glucocorticoids, especially in an older population, osteoporosis, diabetes, cataracts, etc. And because of the toxicities of glucocorticoids, the guideline committee reached a consensus to conditionally recommend tocilizumab with glucocorticoids over glucocorticoids alone. Or I should step back. We recommended use of steroid-sparing agents with glucocorticoids over glucocorticoids alone. The two steroid-sparing agents we generally consider are tocilizumab and methotrexate. Most of us feel that the steroid-sparing effect of tocilizumab is stronger than the steroid-sparing effect of methotrexate. And that's why, most of the time we feel practitioners would probably opt for tocilizumab. But we do recommend a steroid-sparing agent with glucocorticoids as a
Fantastic. So it sounds like the main reason is to decrease glucocorticoid exposure more than that one medicine or one combination may be more effective than the other?
I think what we have data for is glucocorticoid sparing. What you're asking is whether or not tocilizumab alters the trajectory of disease. Is it a true disease modifying agent like we think about with methotrexate or for rheumatoid arthritis? I don't know if we have an answer to that yet.
Okay. Interesting. And do you think, now that you're proposing getting large vessel imaging for everybody diagnosed with GCA, would you treat patients differently if they have aortic involvement, or would you follow them differently because of the findings from the imaging that you recommend?
So past observational studies have suggested that patients who have large vessel involvement, for example, aortic involvement, have a higher rate of mortality. So for patients who have large vessel involvement, we would conditionally recommend use of glucocorticoids with another agent over glucocorticoids alone.
Good. And how do you monitor a patient with GCA? Should we trend the CRP? Should we do repeat imaging? Should we do symptom tracking and seeing if patients are having recurrence of the symptoms that they initially presented with? Should we do all of the above?
Yes, I think in developing these guidelines, it reinforced our absolute need for an accurate and reliable disease activity indicator for both large vessel vasculitides under consideration. For monitoring in GCA, it has to be a multimodality approach, symptom monitoring, inflammatory marker monitoring, and for patients who have large vessel involvement, imaging monitoring for their large vessel disease. I will say that, of course, caution when using inflammatory markers to monitor disease activity. We know elevations can be nonspecific. So we also have a recommendation in the guideline where we say we would not increase immunosuppression based on increases in inflammatory markers alone. Often I'll get patients who come to me and say, gosh, I got restarted on prednisone because my SED rate went from 15 to 40. And it makes me cringe because we really should not be using those markers in isolation. It really should be taken with the whole clinical picture.
Yeah. And then again, I'm going to ask you a question that you probably don't have an answer to, but it's something that we get confronted with in our clinics all the time, is how long to keep patients on treatment. Patients that with GCA, you start tocilizumab and glucocorticoids, you wean down the glucocorticoids and they're still on tocilizumab, and you continue them for a year, 18 months, do a year and then start to wean down the tocilizumab.
As you say, we don't have an answer to this question. Overall, it's not terribly attractive to think about keeping patients on therapies forever and ever and ever. And because of that, I think it's reasonable to start thinking about stopping whatever agents they're on, prednisone, tocilizumab, methotrexate, at some point during their disease course. What that point is unknown. Most of the time we say 18 months, primarily because of our experience in other, vasculitides that we generally keep patients on therapy for 18 months. But, we really have no good data to answer the question.
And any other sort of interesting findings or questions that the group brought up regarding the diagnosis or treatment of GCA?
I think one of the big questions that remains in large vessel vasculitides is how to interpret imaging changes. So, what constitutes, what can be interpreted as active disease, what can be interpreted as just disease progression, scarring after a period of active disease, and how should changes in imaging be incorporated into treatment decisions. I mentioned, FDG PET as, being studied as an indicator of disease activity. We really need a better understanding of what the clinical consequences or long-term outcomes of various, imaging changes are in these diseases so that we know how to react appropriately when it comes to treatment decisions.
Great. Let's shift gears a little bit and talk a little bit about Takayasu's. I've seen fewer cases of Takayasu than I have in GCA. Unlike GCA, I've definitely seen it in some children. So how should we think about treating patients with Takayasu?
So with Takayasu's, I think initial therapy, we conditionally recommend a non-glucocorticoid immunosuppressive agent along with glucocorticoids. I mean, this is a disease that by definition has central large vessel involvement that has potential, significant outcomes. So we would recommend aggressive therapy. What that non-glucocorticoid agent is of debate. Most of the times it's methotrexate as first-line therapy, but methotrexate, azathioprine, TNF inhibitors can all be considered in this situation. I think the question, we were just talking about tocilizumab for giant cell arteritis. The question is whether or not we should be using tocilizumab in Takayasu's. And I think, unfortunately, that's a complicated question. So there was a randomized controlled trial of tocilizumab for the treatment of Takayasu arteritis. I think we all recognize that it was an underpowered study, small sample size. And because of that, it did not reach its primary endpoint. It did not make its primary endpoint in the intention to treat analysis, but did see a significant difference in effect when it came to the per protocol analysis. So currently, though, because this technically is a negative study, we did not necessarily include it as one of the, preferred non-glucocorticoid therapies. And for patients who relapse, we have a conditional recommendation where we would recommend TNF inhibitors over tocilizumab. But hopefully in the future, we'll gain more experience. We may gain more experience with tocilizumab and Takayasu's, and, with more data, this recommendation may change.
Yeah, I mean, I think one of the great things about the guidelines that I really enjoyed reading is that last paragraph about, what questions need to be answered. And I think for anybody out there who's wants to write a grant or get funded for something, this is, after how many years of work that the
4 years
team,
of work. Yeah.
4 years of work, you guys have thought that these are the most important questions to answer for these diseases. So if somebody's out there interested in starting a research career, I recommend everybody to read that last section about questions that need to be answered because they're very interesting.
Secret confessions. That's actually why we put that in there. We desperately want to inspire more people to look at these questions so that we have better data going forward.
I love it. How should we think about monitoring patients that are diagnosed with Takayasu's?
So Takayasu's is a disease where imaging plays a major role. I suspect your experience is the same as mine. There aren't vascular surgeons who want to go in and biopsy the aorta to assess disease activity. So imaging plays a large role. And so in the guidelines, we have a fair number of recommendations on what to do when when looking at longitudinal imaging studies for Takayasu's. Inflammatory markers play a role as well. And as we were talking earlier, they're nonspecific. So it's clinical symptoms plus imaging plus laboratory markers.
Great. Is there a role for surgery in these patients?
So I think there's a role for surgery when you have essentially irreversible complications. So let's say you have a patient and they have worsening claudication symptoms in their arm. We would conditionally recommend immunosuppressive therapy first. So if we can calm down the inflammation such that the patient can develop collaterals around their areas of stenosis, that would be our preferred, treatment path. But, truly, if a patient is having ischemia, digital infarctions, other tissue-threatening events, then that would be the time to consider surgery. But we would recommend trying immunosuppressive therapy first, unless you're in a critical situation.
Yeah, I think, that's one of the things I liked about the guidelines. It sounds like they were written by internal medicine and rheumatologists as opposed to surgeons, because in every case that I think, surgery was being considered, the favored option was increased immunosuppression. In almost every case.
Yeah. I think surgery has a role when you don't have time to develop collaterals, or there is truly something critical going on. But in other situations, especially for Takayasu's, we recognize that collaterals can develop.
Great. In particular to Takayasu's, any other questions or interesting things that the committee found?
Just to build on our previous conversation about surgery, I think one thing we also recognize that if surgery were to occur, there are much better outcomes when the disease is quiescent. And so if at all possible, to have the disease be under control prior to going into surgery. And that may mean considering perioperative glucocorticoids to try to get the disease under as much control as possible before going in and doing the intervention.
I don't think surgeons like steroids very much.
I don't think surgeons like steroids very much because of wound healing, but I'm also pretty sure surgeons don't like for their surgeries to fail, their grafts to fail and such. And so having the disease under control, we think, increases the success of those surgeries.
Awesome. Sharon, this has been a great discussion about the large vessel vasculitis guidelines by the ACR and Vasculitis Foundation. And I hope everybody joins us for the third episode in this series where we'll be discussing polyarteritis nodosa. Sharon, thank you so much for your time.
Thanks, John.
I hope you enjoyed our discussions about the 2021 ACR Vasculitis Foundation's recommendations for the management of giant cell arteritis and Takayasu arteritis. Don't miss the third episode of this series, where we'll discuss the latest recommendations about the diagnosis and management of polyarteritis nodosa. And if you haven't already, please check out our previous episode where we address the recommendations for the management of ANCA-associated vasculitis. That's it for our show today. Don't forget to rate and subscribe to our show on Apple Podcasts, Spotify, or from your favorite podcasting app. You can also find all of these episodes and notes for our show on acronair.org. Until next time, please get yourselves and your patients vaccinated. And as always, stay healthy.